Nice to see you as well.
You are in Detroit now?
I am.
Great. I will be there this weekend. Will you be at OPCI,
Yeah,
Michigan?
I'll see you on Saturday.
Yeah. On Friday night, actually, we have a dinner.
Yeah, I won't be able to make the dinner. I had too many
Ah,
dinners today already, so this week, but I will see you Saturday, hopefully.
nice. Yeah, let's wait for a few minutes more to see
Sure,
who's
Professor.
joining us. And thank you, Eman, for taking care of this.
Oh, sure. Don't worry about it.
And then we can start. So we have Sarah. Sarah, it's 5 a.m. Every time I see Sarah, I try to calculate what's the time over there. And Sarah is active from
Yes.
4:30 in the morning to like midnight.
Mm.
Yes,
It's amazing.
appreciate. Yes, I live in Vancouver. Yeah, pleasure to meet you.
Yeah, you are in Vancouver, yeah. And then we have your fan in Cleveland, from Pakistan to Cleveland. We have Eman from the
Bahrain,
Middle East to Korea. You're in
Korea.
Korea now?
Yeah.
So it's
So
like 8 p.m.,
10
right?
p.m. right now.
10? Oh, it's 14 hours. Oh my God.
10 p.m. Yeah.
It's a lot.
This is why
Then
sometimes my timings are inconvenient for you guys. It's too early, but like you have to keep it in the middle.
oh yes, but
Yeah.
what you're doing is amazing for the lessons. So we will
No
accommodate
problem.
to you.
Well, thank you. Thank you.
Then we have Wojtek from Poland. How is your leg, Wojtek? You are muted.
Yeah, the leg is going better. Leg is general. Thank you for it's going better. It's going
Okay.
better. So next week I come back to hospital.
To work. Okay. Okay, nice, nice. That's great. Then we have Bharat. Hey man, congrats for the CTO that you recently
Hello, you saw that. It was a tough case, man.
I saw it, but it's probably the order where you sent the images is not correct, because I couldn't understand it, all of the steps that you did on my iPhone. But I saw the final result. It's amazing.
Yeah, yeah. So lots of IVUS use, and not too bad. Like 180 mils of contrast, 2.5 hours. Not bad. This
Wow.
was a good effort, yeah. But spent the afternoon that. So I mean, I'll bring him back for the relook, and then we'll see. I hope it'll be healed and nice.
Yeah, yeah. That's a good idea, not to stand after what you've done.
Yeah.
And then so Bharat is from Singapore. There is it's 12
9
hours,
p.m.
no, Singapore.
9 p.m. here.
9 p.m. Yeah. So I'm 1 hour
Oh,
behind
13, 13,
Korea. Yeah.
Korea.
Yeah.
Then we have Ibrahim, and we have Filippo from Italy, and we have Jazim, who just joined. I think we can start. We have now, Eman will present my friend Babar Basir, which is an opinion leader, and it's very close to Cleveland. Actually, it's 2.5 hours only away from us. And I'm really, really happy to have you, Babar, here, and thank you for accepting this invitation from DCB Academy.
Okay. Good
Eman,
day.
please.
Good day, everyone, and welcome to today's DCB Academy session. It is my pleasure to introduce Dr. Mir Basir, the Director of Acute Mechanical Circulatory Support Program at Henry Ford Health System in Detroit, and a recognized leader in protected high-risk PCI and cardiogenic shock management. Dr. Basir, we are honored to have you here with us today, sharing your insights on mechanical circulatory support in high-risk PCI. You have the floor, Dr. Basir.
Yeah, so firstly, thank you so much for having me. To Iman, Bernardo, Ibrahim, thank you for the kind invitation. I really appreciate it. And I think this is really a timely topic, actually. We have two large-scale randomized controlled trials that are going to be presented within the next 1 to 2 years that are going to reshape the entire field of complex and high-risk PCI. And so I think my goals for this talk is to really talk about, when should we consider revascularization in these patients, what the benefit is, and then talk a little bit about the role of hemodynamic support devices as well. So these are my disclosures, and these are the objectives. So I'm going to help hopefully identify the key elements of when revascularization should be offered and talk a little bit about the different perceptions that each group has, patient and family, referring physicians, and what that, difference is, because I think it's really an important aspect, particularly for younger operators. And then we'll focus a little bit on what are the key elements to identify if a patient will derive benefit from MCS, whether that's through ischemia viability and in specifically with MCS invasive hemodynamics. We'll describe a little bit about some of the data from some of the randomized clinical trials that have been done, and then future studies and technologies. And I promise that I won't take the full hour either. So, I think the first and most important thing is that epicardial disease is one of the most frequent causes of heart failure, whether that's acute myocardial infarction or whether that's chronic ischemia in the form of hibernating myocardium. Clearly, coronary artery disease is one of the leading causes of a heart failure. And so the use and consideration of MCS or revascularization as a whole in heart failure is an important topic. And there's significantly plausible reasons for why revascularization helps these patients, right? You may be preventing future myocardial infarctions, but most importantly, you're trying to reverse that hibernating myocardium so that patients can actually recover their LV functions in particular. And when we talk about this, when we study it in particular, I'm really focusing in on the severely reduced EF patients with an EF less than 40%, but you can talk about some benefits that were even demonstrated in the ischemia trial for those patients who had a mildly reduced LVEF as well. And the bottom line when thinking about all of this is that, the outcomes are worse for these patients. So there's a 30% worse 5-year survival in patients with ischemic heart failure with mildly reduced EF when compared to non-ischemic heart failure patients. And so it's important to just keep in mind the morbidity and mortality associated with these patients and why there's such a focus in trying to get them to feel better. Now, the reason that we talk about heart failure and revascularization to start the topic is because every time you talk about MCS and high-risk PCI, you have to think about yourself, what you're ultimately trying to achieve. And it's important to recognize that patients in ischemia, courage, any of our stable ischemic heart disease major trials, they were actually excluded from these trials. And so, the data within this realm has not been there for some time. When you look at the ischemia trial, everyone can look at it at any trial with different views, and I think overall it gives us a lot of benefit in terms of our ability to be conservative and treat patients with medical therapy. But there were some signals, particularly the signal in patients with an EF of less than 45% and a history of symptomatic heart failure, where these patients did better with invasive over conservative therapy. Now, any sub-study, and I'll be talking about a lot of sub-studies today, it's important to keep in mind that this is really hypothesis generating data. But regardless to say, it is important to keep in mind that symptomatic heart failure, even within the ischemia trial, a generally relatively conservative trial design, actually favored the invasive approach. And so for our standard of care with revascularization in heart failure has remained the STITCH trial, a trial that was done 20 years ago. And so it's a trial that hasn't really, changed our perception of the role of revascularization, which is that generally patients with multivessel disease and reduced heart failure get recommended CABG. And, it's important to keep in mind that while STITCH did not show a difference in outcome at 6 years, when you look at the 10-year data that was presented, there was a reduction in mortality, whether that and cardiovascular mortality in specific, all-cause hospitalization. And it's important to keep in mind that these patients ultimately ended up doing better with a revascularization. But clearly, any critic of revascularization within the PCI space is going to say, hey, this is a surgical trial. This is not a PCI trial. And those are two different modes of revascularization. And so you need a PCI trial. But when you look at the guidelines in multivessel disease in patients with coronary artery disease and a low EF have essentially been pretty silent on the issue. Ultimately, if they're not a surgical candidate, the recommendation is to have a heart team discussion and allow for expert opinion to play the role. So it is not supported nor negated within the guidelines. It's only there as a possible mode of revascularization. And the reason that that's been the case is because up until the last couple of years, there was really very little data from a randomized clinical trial standpoint, at least for revascularization with PCI in heart failure. Now, when you look at this meta-analysis that was done comparing an approach of invasive versus conservative strategies in patients with heart failure, I think there's a couple of really important highlighting points. So one is that revascularization as a whole within this meta-analysis demonstrated improvement over optimal medical therapy. But it is also important to know that the cabbage arm of this meta-analysis essentially carried the bulk of the weight. So cabbage was shown to be showed significant improvement in survival compared to PCI that persisted, particularly amongst patients with left main and PROX-LAD disease. And cabbage compared to PCI was associated with a significant reduction in the risk of MI and the risk of repeat revascularization. And so, this is where we are as a whole with the role of revascularization in heart failure. And then became this monster, extremely important trial, the revived BESIS trial. And this was a really important trial for lots of different reasons. Firstly, a kind of a well-powered 700 patient trial. The average age was 70 years old. It was a male predominant trial. And what the trial's ultimate goal was to look at revascularization with heart failure compared to optimal medical therapy. Now, really, really important to focus on the bottom right-hand side of your screen and to really be able to identify who these patients were, because this is a heterogeneous group of patients. So within this cohort, 75% of patients essentially had class 1 or 2 angina. So they were shorter breath when doing pretty exertional activities, but on a general day-to-day basis, doing things in and around your home, they weren't having a lot of resting, regular baseline symptoms. The other thing was similarly about 70% of patients had no significant angina, so they weren't having chest pains and things like that. And then these patients did, however, have multivessel disease, right? So 40% had 3 vessel, 49% had 2 vessel, and so it's important to keep in mind. Now, this trial had basically a few different reactions from people that I had met, right? One was, kind of the gung-ho interventionalist was like, well, this was a dumb trial. These are all asymptomatic patients, and of course they don't get benefit from revascularization. But honestly, that wasn't the going discussion about these patients. I think many of us, myself included, thought by revascularizing patients who have a low EF, even if they're not very symptomatic, that we would improve their long-term outcomes. And I think in BESIS, at least for the follow-up that was shown for the first 4 to 5 years, it was actually, pretty well taken that optimal medical therapy in a contemporary practice was actually very beneficial for these patients, and it did not result in any acute harm. And so now we're able to have a more nuanced discussion with our patients where probably every week in the office, I will tell asymptomatic patients that, hey, listen, with medical therapy, you're going to do fine for the next 5 to 6 years. And if along the way you have symptoms and you're having problems, well, we can always revascularize you at that time. We're not going to make it harder for us to wait a year or two most of the time. And so this was a really, really fundamentally important trial. Now, why do I spend all of this time discussing this? Because ultimately, I think as I've matured, I realized that we have to really be cognizant of which patients we're talking about who derive benefit from revascularization as a whole, and then as part of that, MCS and revascularization as a whole. So that's why I felt that it was really important to kind of give you this background. So, what are the goals when utilizing mechanical circulatory support in high-risk PCI? And I think it's important to consider this in two different aspects. One is that the ultimate goal is to reduce the procedural risk of hemodynamic compromise, right? So while you're doing the case, you want to have some level of stability so that you can do all of the things that you need to do to be able to optimize revascularization. So you want to be able to do a bifurcation. So you want to be able to do simultaneous kissing balloons, to be able to do pot. You want to be able to do atherectomy, maybe, whatever you want to do to optimize that revascularization, you want enough hemodynamic stability to be able to do it. Now, doctors as a whole and interventionalists as a whole have very, very good outcomes in the procedure. And the reason that's the case is if something bad is happening, we're going to change our practice. We're going to, deflate the balloon. We're going to stop doing atherectomy. We are going to limit some of our revascularization efforts because of the hemodynamic compromise that we are seeing. And so in the trials, it's really hard to evaluate intraprocedural hypotension, for example, because operators change their practice when they start to see it. Now, the second major goal of MCS in high-risk PCI is to provide close to or reasonable complete revascularization. Now, I'm not, a zealot on complete revascularization. I don't think that you should, for example, do extremely high-risk procedures for very complex CTOs in the hope of revascularization. Those patients most likely benefit from CTO intervention only for refractory symptoms. But regardless to say when that's not the case and it's not, putting the patient at extraordinarily high risk, then the goal of our intervention as a whole should be to try to provide complete revascularization, not just in one setting, but it can be staged. But we think that that is going to be the best method of preventing complications down the road, and most importantly, improving our long-term outcomes for our patients. And that has actually not been well studied yet. There's hints of it that I'm going to talk to you about, but I think this is why particularly the Protect 4 trial was needed with a follow-up period of 3 years so that we could actually evaluate these patients for a longer period of time. So how do we define high-risk PCI? Who are these patients that are potentially going to benefit from mechanical circulatory support? So I think there's a couple of different ways of breaking this down, but I'll start with this. So there's patient factors that definitely make patients high risk. Age, heart failure, all the comorbidities that we're used to seeing. The more of these that are present, the higher risk our patient becomes. And to be honest with you, even one factor can be a high risk, right? So if you have a patient with severe lung disease, for example, right? During the procedure, you causing ischemia and maybe exacerbating their heart failure on top of their lung disease may require an intubation, and then that intubation leads to a lot of other sequelae. So even that one aspect can make the procedure potentially high risk. But these are non-modifiable risk factors. It's a patient's inherent risk that makes everything riskier. So in the example of the patient with the severe lung disease, for example, putting in a support device isn't going to change that patient's lung disease. It's also not going to make a 90-year-old patient 50 anymore, right? So MCS doesn't alter this risk, right? And actually has the potential of increasing the risk, right? Because patients with, for example, peripheral arterial disease who are going to get a support device, you may be dealing with the complications of that support device. So it's important for consideration of MCS to keep these patient factors in mind, but it's less likely that these are going to be really modifiable factors. What these factors actually represent is the ability for the patient to tolerate hemodynamic compromise, right? And so when you have a lot of these things, then clearly you don't want the patient to have hemodynamic compromise because if something happens to them, they're already in a kind of sickly state, to say. So the second aspect of this is to really focus in on anatomic complexity, right? And as interventionalists, these are all the kind of things that we are accustomed to, right? Whether you're doing multivessel PCI, unprotected leaf PCI, a last conduit, CTO, severe calcium, tortuosity, bifurcation. There's lots of different anatomic complexities that can actually make a procedure more difficult. And it's important to keep in mind that this is also not modifiable, and I mean not modifiable by an MCS device. And what is important, and I've definitely gotten some pushback in this, but I do believe it to be true because I mentor and help a lot of young interventionalists, which is that there is some variability um, about how quickly you can get through these procedures based on an operator's experience, right? And so when you have someone like, for example, Bernardo, who's very, very good operator, does very complex CTOs and has a lot of experience, doing a unprotected left main with an EF of 30%, and let's just say even requiring atherectomy, I can imagine many, many situations where he would feel comfortable and confident doing that without a support device. Whereas a younger operator or less experienced operator may require more time to do all of those same steps and may actually derive some benefit in hemodynamic support. But regardless, to say the support device as a whole doesn't alter the anatomic complexity of that patient. And so again, anatomic complexity is important when deciding on MCS because the more complex it is, the more likely you may need prolonged ischemia, or you may cause prolonged ischemic times and benefit from the hemodynamic support. But again, it is one of the factors, not the sole factor, for defining high risk PCI. And so my first take-home point for this section about complex PCI and the need for hemodynamic support is that if you look at actually by the numbers, the majority of high risk and complex PCI can be done without the need for hemodynamic support. And it's important to keep that in mind. Now, this is a very nicely done study from our friends at MedStar who basically demonstrated the ability to do high risk PCI without hemodynamic support. And they had 1,600 patients, and their 30-day mortality was 1.6%. And the use of rescue balloon pump, not even Impella, was less than 1%.
But
Now, when you
uh,
look at,
about,
sorry, go
sorry,
ahead, Bernardo.
this, how was the LVF in this cohort, the median?
I'm going to get to it right now. So when you
Okay,
look at
thanks.
how you define high risk PCI within this cohort, you can see that they defined it based on the following high risk features. So 8.4% of these patients were complex because they had unprotected left main. Just under 20% had a last patent conduit. Only 23% here had an EF less than 35%, Bernardo, to your point. The majority, the main criteria, the high risk criteria that was done was reported to be multivessel coronary artery disease, which was around 45%. And then there was a few patients with severe AS and a patient with severe MR. And so
Yeah, so
this
the
is
high
how.
risk milieu of this cohort of patients is debatable.
That is correct. That is correct. So right, so we're talking about doing multivessel PCI, and at the end of the day, we do multivessel PCI every day, I think,
Yeah.
without hemodynamic support device, right? But it's important because people can overly describe the MCS high risk PCI cohort to mean that it's any high risk feature, and clearly, I don't think that that is reasonable. But the important thing in this study was that 3/4 of the patient actually only had one high risk feature. And one high risk feature as a whole, it can still be high risk, but that alone is really not the trigger for these very sick and hard to treat patients. So it is true that all high-risk PCI does not require MCS, but there's a lot of heterogeneity in how we define high-risk PCI, particularly for people who are defining it very broadly. But the most important factor when deciding on the need for support device is actually hemodynamics and the risk of hemodynamic compromise for your patient. And so hemodynamic compromise to me is the foundation of making the decision on when to use hemodynamic support. And it goes beyond just LVEF. I think LVEF is a very important marker for us to, make people think about hemodynamic compromise, but it can occur in other settings as well. But it also is something that we don't typically evaluate very strongly, meaning to say, you may have an EF on your patient and you probably have your systolic blood pressure when you're doing a case, but how many times do you actually use a right heart cath, evaluate the hemodynamics of the patient, evaluate the filling pressures of the patient, evaluate the RV function of the patient invasively to be able to help
Yeah.
guide your procedures?
Babar,
And I think in really complex PCI, that's
let me
important. Sorry,
interrupt you
Bernardo.
because this is an extremely important point, and for me, it became a very important learning point. So I want to know from Bharat, if you are active, from Ibrahim and Rima, we and Wojtek, if you are still here, and Amit. So which is your when you deal with a complex PCI, LVF reduced. So in how many cases do you calculate the cardiac output? Do you do right heart cath assessment and all of these measures? So in how many cases do you base also the timing of your procedure and whatever is done before on these measures? Eban?
I don't recall doing that, any of these measures, honestly.
And Bharat, are you here? What do you do in
I'm here.
Singapore?
Yeah, we do. I mean, we use surrogate sometimes, so not every case we would do a right heart, but we do use the LVEDP.
Okay.
And then we have a lactate. We have a point of care lactate most of the time. So we can send off a lactate very quickly. And
Lactate for a stable patient? You do lactate for a stable patient?
No, of course, not for stable patients, but sort of. I mean, we do use MCS.
I'm talking about high risk PCI, not cardiogenic shock.
Okay, yes, yeah. So I mean, we not always. No, maybe 50% of the cases right heart cath.
Okay.
With for impeller cases, yeah.
No, I interrupted you, Babar, because this is something that I learned, to be honest, more in the US. This is something that in Europe, to be honest, is not that common to do not during the same procedure, but the days before, a complete right heart cath assessment. And when I came here, I was surprised at how many right heart cath, are being done at least in my system, and probably there are too many. But for these patients, I think that the information that you may achieve in order to bring the patient ready for this type of intervention can be very useful.
Absolutely. I think of it in the same exact way because honestly, in my view, this is the actually most important modifiable risk factor for these patients. And I don't mean to suggest that MCS is the only way to alter this. Once you know where the reserve of the patient is, it gives me a lot of confidence, for example, to say, hey, listen, there is some reserve on these patients. I'm going to just put them on some norepinephrine and do the case and see how that goes. And as long as I can get through the case, because I know there's some reserve, it'll be fine. Or I keep a sheath in as a backup, for example, right? But when the hemodynamics are poor and I'm get worried about doing the PCI, that's where putting in the support device up front, giving these patients, some stability is then becomes really, really an important aspect. And so I think that when we talk about complex PCI and high-risk PCI, this is something that has not been done very much so. And if you look at all PCIs, all complex PCI, use of right heart cath in general is less than 1%, right? So it's something that
Wow.
we're just starting to kind of focus in on and learn more about. And here's a study that we did that kind of helped show that if you actually define needing support device, like how would you be able to tell somebody needs a support device? Well, one of those ways is if during the case they lost pulse pressure, right? if if a patient was reliant on an impella during the case, then clearly without the support device they would have become more hypotensive, and then badness could have ensued. And so we looked at protect 3, and we divided patients who had the hemodynamic logs from the Impella console alone. And so we derived patients who had loss of pulse pressure versus those who did not have loss of pulse pressures, right? And again, if you have loss of pulse pressures, that means without MCS, you would have developed hypotension and all these other issues. And this is what the console looks like when you have loss of pulse pressure, right? So the patient loses pressure as demonstrated by these red X's. And then, this is, and what we did was we defined it as being associated with a drop in systemic blood pressure. And then we also defined it by at least being for 5 seconds and then being separated out by 10 seconds between each, different factor. And so when you ask yourself what predicts these loss of pulse pressure episodes, well, we looked at lots of things. Interestingly, age, gender, the EF even didn't make a difference to be able to predict whether you were going to lose pulse pressure or not. The more vessels you treated didn't pick it. Atherectomy, which I personally thought was going to be a factor, didn't. PCI of the last conduit, when you were doing more revascularization, all of these things didn't change with being dependent on a support device. What actually was the reason you were dependent was because at baseline, you had a lower systolic blood pressure, a lower mean pressure, decreased cardiac output, decreased cardiac index, higher heart rate, greater cardiac output deficit, right? So it was the hemodynamics that made you dependent on the device. And it was very predictive. And this is why right heart cath is important. Because when you have, it's not that the features on the left aren't important, right? It's that when you have the features on the left, you get a right heart cath, and then you decide that if you have a lower blood pressure, lower cardiac output, a higher cardiac output deficit, then these are patients that you may want to definitely, use upfront hemodynamic support.
Yeah, but let me
And
ask
so,
you a question. Sorry to
yeah, yeah.
interrupt, Babar. So do you think that instead of basing the decision on LVF, this is what's happening in the world. So you base your decision on LVF, that's it. So we should instead put also, in the guidelines, clearly that we should rely on other measurements when to decide and how and when to intervene with a mechanical support.
So I think it's important beyond LVEF for sure. Yes. And the reason I think we're going to all go down this road is, we don't know what Protect 4 is going to show, right? But Protect 4 has an EF cutoff of less than 40% and complex PCI.
Yeah.
So what percentage of those patients right now are even getting hemodynamic support? In the United States, it's a minority. Worldwide, it's an extra minority, right? And you know this
Yeah.
better than I do, right?
Yeah.
So we do these cases all of the time without support device. But I think there are some patients that we're under treating with support device, particularly when we look at it worldwide because of cost and availability and other issues. But then I think in the US, we're also doing the same thing because we don't actually understand the hemodynamics. And there's a small group who's overusing hemodynamic support devices because they're looking at just EF and complex PCI and then putting in a support device, right? So that's why it's the balance of talking about this with both groups and really, I think, using objective measures to be able to help decide that point. And it's really important, Bernardo, because we're about to get a whole host of 8, 9, 10 French support devices, right? And so it's going to be
Yeah.
safer and easier to put the support
Oh, sure.
devices in. And so you have to ask yourself, who we should we really be putting it in?
Fully agree.
So if you can actually, so this is the chip score that was derived out of the UK, right? And one of the things that's important about this is that this is a nice scoring system to be able to help define the absolute risk of your PCI. But what's really important about the chip score is it's about cumulative risk, right? So when you have the cumulative risk of a patient, that's when these patients start to have riskier procedures. And what was really, really interesting to me is that at least in the UK, in a more conservative environment when using support devices, when you did use the support device, they were doing it in the absolute riskiest patients, right? And so the hazard ratio here was around 7. And the reason for that is because they were really doing it in patients that had multiple high risk features and issues and concerns. But ultimately, when we decide as operators to use it, and I think we're going to learn this in both BSIS 3 and in Protect 4, which is that there was a lot of cumulative risk that was associated with these patients beyond just looking at 1 or 2 risk factors like the MedStar group had done. So when should operators consider MCS? Well, you look at your patient factors, you look at your anatomic complexities, but the foundation of your decision needs to be on the risk of hemodynamic compromise. And when you have all of those features, which is actually present in the majority of patients, but again, based on hemodynamic compromise, that's where high-risk PCI with upfront prophylactic MCS becomes a really, really important thing. Now, it's important to keep in mind that MCS definitely alters these hemodynamics. I mean, it is something that is really protective both within the case and then subsequently after the case that I think is important. So this is a case that we did. We did rotational atherectomy down the LAD. Then we fixed the subtotaled LAD and circ. And we did this with a pressure volume loop. Okay, so this is actually our pressure volume loops. So the first screen here is the light blue represents the patient's baseline. And so when the impella goes on, you get a leftward shift. So the patients have less volume, slightly higher blood pressure. Then what you see is now the light blue has become your baseline on Impella P8. So what happens when you're doing atherectomy on the LAD? And I didn't show the atherectomy pictures, but it took us about 5 runs of atherectomy and it was longer runs. But what you can see is the blood pressure that was in the 130s dropped into the hundreds. But the volume within the ventricle went from about 180 cc's to about 240 cc's, right? And so it was a complete rightward shift. And then what you can
This
see
is
on the
amazing.
on the
Amazing
last
case.
screen is that we think that it may be just atherectomy, right? Like all of this showering from a rotablator, we talk about it as being insignificant, but honestly, we in clinical practice, when we see it in a low EF patient, it can be significant. But this is just a 10-second balloon inflation, right? And look what happens. Same thing. You go from a blood pressure of 130 and you go down to 100 and now your volumes, and remember, this is a cumulative procedure. So the patient never got back to 180. They were now resting in 190, but now the volumes are 260. So you can see that even with an Impella at P8 doing this case, each insult was resulting in some hemodynamic shifts. And so the longer the case went, the more volume the patient had, the lower the blood pressure they had, and that's even with a support device. And if you replicate these studies without support devices, and we have some of those patients as well, but much less riskier procedures, there is a decremental change throughout the case. And the simple way to do that is people who measure LVEDP, as our team member said earlier, that's a great way of being able to see what impact you had on the ventricle before the case. You started with an LDP EDP of 15, at the end of the case is 35. Well, you should probably watch that patient a little bit more closely, right? But these are the things that are important hemodynamically to be able to help that decision. On the bottom of your screen, we would also put in different kinds of support devices, balloon pump, tandem heart, and Impella, and measure coronary perfusion pressures past really stenotic lesions. And one of the things that Mort Kern showed, I think 20 years ago, was is that hemodynamics, your coronary perfusion pressure alters with balloon pump until you get to 50, 60% lesions. After that, it doesn't really change the distal bed very much with a balloon pump. But we showed with an Impella and also to a certain extent with a tandem heart that when you had more robust support devices, that you could actually change the perfusion pressure of a distal coronary past the stenotic lesion up until it was like 99%. Up until your wire became occlusive, you were actually able to alter that coronary perfusion. That becomes important because if you're doing multivessel disease and you're doing a PCI on the LAD, but have severe disease on your right and circ, for example, or vice versa, it becomes a protective mechanism as you're working as well. All right, so let's get into a little bit of the data. So there were two major trials that have been done in MCS as prophylactic devices. So the BESIS 1 trial compared routine versus rescue intra-aortic balloon pump. It's 300 patients, no difference in outcomes within the first month or at 6 months. But if you follow these patients for a longer period of time, out towards the 4-year mark, the patients who were treated with balloon pump who had also gotten slightly more revascularization tended to do better. Very, very hypothesis generating. Don't get my blue text to be too important for you, but it is important to appreciate that the curves separated after about 6 weeks, right? And so after this part, you can see that there were patients who it seemed to have done a little bit better. And it was clear within the study that a balloon pump did offer some peri-procedural improvements in hemodynamics, but clearly that's something that we would expect. So there was less intra-procedural hypotension, which allowed the operators to do a little bit more work. It's almost the same story with the Protect 2 trial. And the Protect 2 trial was also over a decade ago. It was only with an Impella 2.5 versus a balloon pump. It was a slightly larger trial at around 450 patients, but there was no difference in outcome at 30 days. But if you, again, look at past the 30 days and you look at, for example, 90 days, you can see that the curves started to separate again. And so the per protocol analysis showed that the patients who were treated with balloon pump had higher major adverse events. And then there was more extensive revascularization with the Impella arm, and that was associated with reverse LV remodeling. Again, only hypothesis generating, right? But what's important is that, again, in the procedure, Impella provided greater hemodynamic support compared with balloon pump. But what you can see is in both of these trials, the curves started to separate the longer you followed these patients. And so the primary endpoint of both of these trials was early at 1 month. And I think what we've found and what we've learned even from the shock world with the danger trial is that there's too much competing risk within the first 1 month. And so you probably need to follow these patients out for a longer period of time to be able to assess the role of hemodynamic support in improving your revascularization efforts in these complex patients. And so in the balloon pump arm, longer term follow-up was associated with slightly better outcomes in the balloon pump arm. And similarly in Impella, at 90 days, there was less, about a 30% reduction in MACE in patients who were actually treated with Impella. Hence, the need for more studies. And so there's two large-scale randomized clinical trials that are going to be done, and I'll probably end here in the next 5 minutes. So the BESIS trial, which is also going to be 300 patients, is going to randomize patients with an EF less than 35%, with a Jeopardy score that's greater than 8, with Impella CP mostly, and compared to standard of care. Standard of care can be no support device. The follow-up duration for that trial is going to be 1 year. This will probably be presented before Protect 4. And it's going to be interesting because right on the heels of this trial, within the year, will probably be the Protect 4 trial as well. And it's an interesting primary analysis. It's a win ratio of hierarchical composite outcomes. And so really curious to see what this trial shows. And then we have the Protect 4 trial, the largest complex PCI trial that's ever been done. I've been privileged to be a part of it. It's going to look at patients with an EF cutoff of less than 40%. Again, randomized to Impella CP versus standard of care that can and does not have to include balloon pump. But to our discussion earlier, I'm really, really excited about this study, mostly because of this right heart cath sub-study. I really feel strongly that this is going to help guide us very strongly in which patients derive benefit from hemodynamic support and which patients or becomes, very important to use hemodynamic support. But there's also lots of other things that we're going to learn. I mean, from a complex PCI standpoint and just from a trial standpoint, there's so many variables. The case report form is humongous. Our research coordinators complain about the study all of the time, but it's really going to answer so many questions. And both of these trials should be presented either in the end of 2026 or the beginning of 2027, most likely. And the last point that I wanted to make with you guys today is that we talked all about, why hemodynamic support devices are beneficial, what they actually do, how to potentially choose them, and things like that. There is a huge amount of work being done right now to make these devices smaller and more powerful. And multiple trials throughout the world are basically evaluating different support devices, but essentially, percutaneous LVADs in the complex and high-risk PCI space. And so where we're going as a field with this is there's lots of MCS non-inferiority trials that are coming. And I wanted to give you some advice on these trials as well. So I gave you this whole spiel because I'm a little bit worried that we're going to overuse support devices, particularly as these trials come out. When these trials come out, they're going to come out with a cutoff that EF less than 50%, and they're going to basically come up with a complex PCI definition. And the earlier trials, BESIS, Protect, these patients were pretty sick. They had multiple comorbidities. I think the justification for using support devices was definitely there. Where we are right now is I think that some of these trials are recruiting low risk patients, okay? And we're going to definitely be able to demonstrate that the device works, and that's not going to be a problem. But what I'm really worried about is if you use a device and it hasn't been tested in the sense of being significantly hypotensive, a device that can go up to the ICU and be managed for 24 hours, that we're going to be potentially getting ourselves into complex situations. So all of these devices, the smaller devices, are self-expanding. ECP, Magenta, Supera, they're all self-expanding. And so they need to be taken in and out in the cath lab, these kinds of things. You can't manage them easily in the ICU, at least from the data that we have so far. So really, really important that when you're asked to do some of these non-inferiority trials, that you really look at these devices carefully and decide which ones you want to use. I think they're going to revolutionize the field. I'm very optimistic that we're going to get better with this. But do be careful in this because we have our best interest of our patient in mind at first, and we want to make sure that they're safe to use in actually high risk patients, not just in lower risk patients as well. So to conclude, from my standpoint, the goals of MCS and high-risk PCI are to provide the intraprocedural hemodynamic support, perform optimal PCI, and your goal is to improve the long-term outcomes of these patients. When you define high-risk PCI, it's really a cumulative risk, right? So if you're going to make this big, broad, high-risk PCI group, well, then yes, majority of patients don't need high-risk PCI. But when you talk about lots of cumulative risk and hemodynamic compromise, I personally believe high-risk PCI with support is advantageous for many, many patients. I think the BSIS 3 and Protect 4 trials are going to really, really help revolutionize our understanding of complex PCI, whether they're positive or negative. And I think those trials are really going to help us identify who gets the most benefit from these things. And regardless to say these devices are here to stay, they're going to be smaller, more powerful. So for early career interventionalists, I think it's really, really important that you have this background as you get the devices. And particularly for an international audience, I think it's important because there are cheaper versions of these devices that are being constructed. For example, I know of a company that I've been working with in China who's going to have it be about 40% the price of an Impella and about a 3.5 liter device. And I think it's going to be able to help our colleagues throughout the world in these complex situations as well. So I hope that was reasonable, and I'm happy to hang out with you guys for a little bit and talk more about this.
That was great, Babar. Thank you. It was a really omni-comprehensive lesson, not only because of the glimpse into the future of these two big trials that I'm really, really eager to see Protect 4. Really, I cannot wait. So, in parentheses, so do you think you will present it at TCT or ESC next year?
So I think BSIS has the opportunity to do that. I think Protect will not. Protect's primary endpoint was at 1 year, and I don't think that all of that data will be available by TCT.
Yeah. But that said, I also liked a lot the slide on the future and future devices and your comment, which is let's pay attention. We learned a lot of lessons from Impella, Protect 2, and then as compared Protect 3 are showing that you should be also an expert in dealing with endovascular procedure, and I would say mostly with a patient selection. In my experience, I had some unfortunate cases of complications related to the access site. In one case, it was an ischemic. In two cases, it was an ischemic complications, and in more, it was a bleeding complication. So patient selection is of paramount importance, and by any of these cases, I learned a lot. So it's important to provide new devices for our colleagues in dealing with complex cases, but it will be of paramount importance, the patient selection and the ability to manage these complications.
Absolutely. And I think the FDA is really looking at these devices much more stringently as the new phase comes in because they know there's going to be a lot of devices available. And so they're really looking at safety. And I think we're going to, be pleasantly surprised, but we want to be cautious as it rolls out.
Yeah. So I think that we have just a couple of minutes for any very fast question by anybody. The lesson was omnicomprehensive, was beautiful, but I think there are many, many questions. We need to condense this really in a couple of minutes. We have another meeting later. If any question is there.
Thank you, Dr. Bashir. So very nice talk. So I think more a comment, but I think patient selection can sometimes be quite difficult. Choosing the right patient and which patient, because like you rightly showed us, a lot of factors that we actually think might be relevant or clinically important for choosing these patients are actually not. And some that you've shown, we may not even test for it. So I think that's a good point in terms of the actual sort of contributing factor. And then, like Professor Cortese said, I think the sort of complications are not inconsequential, and so having an expertise and even dedicated training, not just for the proceduralists, but the support staff thereafter. If they go to CCU or ICU, being able to care for those patients, to look out for symptoms of limb ischemia, to know how to put a backflow cannula in, or do you know what I mean? Like those sort of things, I think are quite important. And at least for us, there's not that much in terms of education from that aspect. There's a lot of support for the actual device implantation, how to use the device, but more the aftercare, I think, is also just as important.
Yeah, exactly. Fully agree. I always mandate my fellow in case we have impella left or in case we're removing the lab to go. So he's mandated to follow the patient in the CICU for the next 6 hours. It's very important. You cannot just say, okay, I need a great PCI, so complex. Let's leave this to the others. It's your duty, you and your fellow. If you have to deal with other cases, it's fine, but your fellow should follow the patient.
Yeah, and honestly, I thought that, I wanted to, at least for this presentation, talk a little bit more about the why and the beginning of it. But we didn't even talk about weaning, for example, right? I mean, there's data from Protect 3, which really shows that even the hemodynamics help you decide who should be the patient who gets the Impella or any device out immediately after the PCI, and who's the patient who, as Bernardo suggested, you leave it in overnight and then take it out the following day, or, some patients even maybe more than a day. But, all of those nuances are things that we're still learning about and that we have to teach others. And because it is ICU management and it's different than what happens in the cath lab. And I'm always surprised by interventionalists who aren't rounding in the ICU or don't have a lot of critical care experience, for example, where they'll just maybe take out a support device so quickly. And then, that evening, a person will come back down for a support device because of ongoing shock.
Yeah, and I had a case where a patient actually had ischemia. They did not call me during that night. I was so disappointed. They called the vascular surgeon, and then the patient ended up doing endotherectomy, and it was an ischemia actually in the iliac arteries. Don't ask me why. It was after removal of the impella, but they did not call me. You could fix it easily. You bring the patient to the lab, you could do just ballooning, a little ballooning or put a stent, whatever. It's so easy, but they call the vascular surgeon. So the message is, this is your patient. Your duty is to follow the patient till discharge.
Completely agree. Completely agree.
I think we have to jump to another meeting. So thank you, Babar. It was really a pleasure. I learned a lot from this lesson. And I'm really eager to see you in a few days in Detroit.
Sounds good. Thank you so much for having me. Thanks for everyone's effort putting this together.
Thank you very much. Very
Thanks,
insightful.
Emma.
Thank you very
Thanks,
much.
Thank you.
Bye-bye.
Thank you.
Bye-bye.
Bye-bye.